Did you recently tear your ACL? Are you unsure if you should have surgery or not? Did you get an MRI that confirmed an ACL rupture? So in today's episode, we're going to cover what research categorizes people as copers and non-copers, and what that means for you in terms of whether or not you should have surgery, either right away or giving yourself some time. So stay tuned. I think you'll like what we got for you. Hey Hoopers, my name is Gabe Ignacio, Doctor of Physical Therapy, board-certified orthopaedic clinical specialist, and co-founder of Basketball Doctors alongside with Dr. Marco Lopez. Our goal with the Basketball Doctors is to empower the basketball community by providing evidence-based information on all things related to basketball in terms of rehab, sports performance, and increasing your ability to play for as long as possible. Again, all this stuff is for educational purposes only, not medical advice. So if you need medical advice, seek out a healthcare provider or send us an email or DM to help see if we can help you meet your goals. And if this is your first time here, we'd really appreciate it if you like, subscribe, comment, share with your family and friends so that we can reach more Hoopers. With that being said, let's get into the topic of the day of copers versus non-copers following an ACL tear. All right, so there's been research that's come out from the University of Delaware that categorizes people as a coper and non-coper. This research is greater than 5 years ago. There's nothing really new that's came out between coper and non-coper, so just a little disclaimer with that information. But to let you know of what categorizes you as a coper versus non-coper is they have four main topics. One is your knee gives away, like gives out, essentially like when you're walking or moving around, one or less in a time frame of after the ACL tear. Two is greater than 80% on a 6 meter timed hop test, single leg hop test of one side compared to the other side. 80% or greater on we call it outcome measure. It's called the COOS and it's for activities of daily living. And then greater than 60% on global perceiving of your knee function. So those are the four main categories that they use for putting you in the copers or non-copers category. And the good thing about this one is that it's a good and bad thing that you can move in the spectrum of being a non-coper or being a full coper. So you can start off as a non-coper following your ACL tear or sprain, and over time as you get stronger and develop the proper mechanics, you can move from that non-coper to the coper side. And then vice versa, you can move from that coper side where you had no instability, all your ratings are good, but then over time that instability comes back as the swelling comes down, the scarring decreases, and then you end up becoming a non-coper. So you have that spectrum moving one side to the other. So there is that caveat with being a coper and non-coper. And we're gonna get into the kinematics and like what EMG studies have shown that can make you also figure out if you're a coper and non-coper. Okay, so now we're gonna go over things that aren't quite as measurable, but you can feel the difference in yourself when you do these activities. So the first thing that they saw in terms of categorizing when they do the research on copers versus non-copers is first your activity function. So typically with copers, you'll see that you'll have less pain, your knee range of motion is pretty much close to full or full, and then you have less pain and that feeling of instability isn't there. Versus non-copers, they have feeling of instability, they have lack of range of motion, it's very painful, and it's very swollen. So those are the big differences in what you'll see in your knee when you're a non-coper versus a coper, is that really making sure the swelling is very minimal, pain is minimal, your range of motion is full, and you have good function in that knee in terms of like walking and moving around. Another thing that they saw in EMG studies is that in the copers, you have preferred co-contraction of your quads and your hamstrings when you do functional activities, and they have them, when they were copers, they had them do some cutting, and they saw that they had really good co-contractions of your quads and hamstrings because they fire together to keep that knee more stable. Versus in the non-copers, they saw that with EMG studies that the quadriceps were preferred for the non-copers, which didn't allow their hamstring to co-contract while they were doing functional activities, which led to feeling of stiffness, instability, and just not being confident in that movement. Another thing that they saw was reported outcomes. A lot of times that when the copers, when they went through their rehab and recovery, they had a higher rating on an IKADC score, which is another self-reported outcome measure, as well as they saw they had better tests with single leg hop testing. So single leg hop testing is very common with ACL return to sport testing, versus the non-copers, they were very reluctant to do any testing at all. So those are some categories that you can see how copers function versus non-copers. And again, these were just based on research when they found someone and categorized them as a coper versus a non-coper. So now that we know the information of a coper versus a non-coper, the question becomes, when do you know, or when should you measure if whether or not you're a coper or non-coper, and like when should you figure out if you need surgery or not? So typically what the University of Delaware recommends is that you perform these testing or objective measures about 60 days after the initial injury, but at least before 6 months. So in that time frame, you're trying to figure out, is the swelling less? Is the stability feeling coming back? Is your range of motion coming back? Are you able to fire your quad? Are you able to walk better? And that big thing is that we tell people is that, how's the stability in your knee? Do you feel like it's giving out? If your knee is feeling like it's giving out and you feel like you're getting stronger or the swelling's getting less, that's typically not a good sign of that instability feeling. But regardless if you're a coper or non-coper, research really supports you doing prehab before having a surgery or not. So regardless if you opt to have surgery or whether you are a coper or non-coper, rehab in the first 6 months looks very similar. So you're really trying to get that quad firing, get your glutes and hamstrings firing simultaneously with that co-contraction and functional activities, decreasing pain, decreasing swelling, gaining as much range of motion as you can, normalizing your gait pattern, and then slowly incorporating like everyday activities. So that's what typically rehab looks like. What they've seen for copers, if you're truly in that category, is that they are able to return to their prior level of activity, maybe not performing at what they once were, somewhere between 6 and 12 month mark. What they also saw, which is interesting, is that if you're a coper and you didn't have surgery, you actually had a high likelihood of developing early knee osteoarthritis. And unfortunately, what we've seen with research is that regardless if you have surgery or not, when you have an ACL tear, you will likely develop earlier osteoarthritis. Research is still coming out if that's a long-term thing or not, if that's still very true, but what we've seen with research so far is that unfortunately, just because the extra movement that happens at that knee and the wear and tear on that meniscus, developing early knee OA is kind of in the future. I hope you guys learned something valuable in learning the categories of a coper versus non-coper, and helps you decide whether you should have surgery right away or not. If you like that video, please like, subscribe, comment, share with your family and friends to help us grow our channel and reach as many hoopers as possible. If you didn't like that video, that's all good. Hit the dislike button and comment below though on how we can improve. Again, we are the Basketball Doctors. Let's ball for life.